Welcome to Sticky Med, learning medicine stick by stick.
Okay, question one kicks us off. It's a pretty textbook picture of Cushing's syndrome, right?
Yeah.
45-year-old man, gaining weight centrally, muscles feeling weak, especially, proximally.
Yeah, and those classic skin changes, easy bruising, the wide purplish stretch marks, the violaceous striae, plus he's got significant medical issues cropping up, high blood pressure, 162/96, and new diabetes, basically glucose at 180.
So the symptoms scream cortisol excess. But the labs, they're the ones that really pinpoint the source.
Exactly. 3 key findings you absolutely can't ignore. First, his 24-hour urinary-free cortisol is way up, confirms the hypercortisolism, no question.
Okay.
Second, and this is the big one, his morning plasma ACTH level is undetectable, basically 0.
Undetectable, that's huge.
It really is. Third, he fails the low-dose dexamethasone suppression test. His cortisol stays high. And then the imaging seals it. A 3.5 centimeter mass found only in the right adrenal gland.
Okay, that undetectable ACTH, it really acts like a compass here, doesn't it? High cortisol makes you ask, what's the pituitary doing?
Precisely. The pituitary should sense all that cortisol and just slam on the brakes for ACTH production. Shut it down completely.
But something is making cortisol anyway, ignoring the pituitary's stop signal.
That's the core logic. So the question asks for the best explanation. Given all that data, high cortisol, no ACTH, no suppression with DEX, and a unilateral adrenal mass, the only answer that fits is D, autonomous cortisol production by an adrenal cortical tumor.
Let's really hammer this home as the archetype for primary hypercortisolism. The adrenal tumor is just churning out cortisol on its own schedule, feedback loops be damned, and that flood of cortisol tells the pituitary, we've got way too much. So the pituitary shuts off ACTH.
Perfect summary. High hormone from the gland itself, low signal from the upstream controller. That's primary disease.
But let me push back slightly. If the ACTH is undetectable and you see the mass on CT, is the dexamethasone test even necessary? Isn't the diagnosis locked in at that point?
That's a fair point, clinically speaking. Undetectable ACTH plus an adrenal mass is pretty much diagnostic of a primary adrenal source. But the DEX test adds that functional confirmation.
How so?
Well, dexamethasone is a potent synthetic cortisol mimic. Give a low dose to a healthy person, and their pituitary immediately cuts ACTH, which then drops their own cortisol production. Total suppression.
Okay.
But this adrenal tumor, it's already ignoring the body's natural signal, the 0 ACTH. So it's absolutely going to ignore the artificial signal from the dexamethasone too. The cortisol stays high. It proves the tumor is functionally autonomous, completely disconnected from HPA axis control, confirms the mass isn't just sitting there, it's the source of the problem.
Got it. Functional proof on top of the structural evidence.
Okay.
Now let's use this rule. Primary disease means high hormone, low upstream signal to systematically take down the other options.
Yeah.
Why isn't it C, overproduction of ACTH from a pituitary corticotroph adenoma, Cushing disease? That's the most common cause overall, isn't it?
It is the most common endogenous cause, yes. But in Cushing disease, the problem starts in the pituitary. A pituitary tumor is cranking out too much ACTH.
So ACTH would be high.
Exactly. High ACTH drives both adrenal glands to get bigger and pump out tons of cortisol. So you'd still see the Cushing symptoms, high cortisol, but the defining lab feature would be high ACTH, or at least inappropriately normal ACTH. That's the direct opposite of our patient's undetectable level. Plus, Cushing disease usually causes bilateral adrenal hyperplasia, not a single large mass in one gland.
Okay, so the ACTH level is the key differentiator there. What about A, ectopic secretion of ACTH, say from a small cell lung cancer?
Similar logic applies. Ectopic means ACTH is coming from somewhere outside the pituitary, like a tumor. These tumors, especially small cell, can produce absolutely massive amounts of ACTH, often way higher than even pituitary tumors.
Leading to very severe Cushing's.
Often, yes. Very rapid onset, sometimes extreme hypokalemia because the steroid production is just overwhelming. But again, the physiological signature is ACTH-dependent hypercortisolism. ACTH would be sky high, not suppressed. So ruled out by our patient's labs.
Makes sense. And option B, pituitary hyperplasia due to chronic stress-induced CRH stimulation.
That's thinking about a hypothalamic cause, where maybe excessive CRH is driving the pituitary. But again, if CRH or ACTH are the drivers, then ACTH has to be detectable, probably elevated, to cause the high cortisol. Any ACTH-dependent cause requires measurable ACTH. Our patient has none. Instant rule out.
Okay, that leaves defective cortisol metabolism, pseudo-Cushing syndrome.
Right, things like severe depression, alcoholism, sometimes obesity can mess with the HPA axis or cortisol clearance, leading to elevated urinary cortisol. It can mimic Cushing's clinically to some extent.
But it's not autonomous.
Exactly. The axis isn't fundamentally broken in the same way. You wouldn't typically see complete ACTH suppression. Failure of low-dose DEX suppression isn't always absolute. And crucially, you wouldn't expect to find a large independent adrenal tumor causing it.
Yeah.
Our patient has clear structural and functional evidence of primary adrenal disease. Pseudo-Cushing just doesn't fit the full picture.
All right, that nails down primary hypercortisolism. Now let's venture into probably trickier territory, congenital adrenal hyperplasia, or CAH. These enzyme deficiencies really mess with the steroid pathways.
They absolutely do. A single blocked enzyme can reroute everything. We're looking at two specific variants here that both, interestingly, cause hypertension.
So how do we tell them apart?
It comes down to a two-part check. You see low cortisol, signs of mineralocorticoid excess causing high blood pressure. Then you must look at the sex steroid profile. Is there virilization too many androgens, or is there a lack of androgen effect?
This is the first hypertensive type. A 14-year-old girl hasn't started her period's primary amenorrhea, and she has high blood pressure. The labs show low cortisol.
That's the key. 17-hydroxylase deficiency. Hydroxylase deficiency also causes hypertension, but it does so while shunting precursors towards androgens. So patients with 11-OHH deficiency present with signs of androgen excess virilization. Our patient here has low androgens and amenorrhea. The sexual phenotype is completely different. It's the critical distinction.
Got it. Low androgens point to 17-OH. High androgens point to 11-OH when hypertension is present. Now, let's quickly rule out the most common CAH overall. C, 21-hydroxylase deficiency. Why not that one?
21-hydroxylase is needed much later in the pathway, specifically to make cortisol and aldosterone. If you block it, you get low cortisol, low aldosterone, and all the precursors get shunted massively towards androgens.
Low aldosterone means?
Usually salt wasting and hypotension, especially in the classic form, the exact opposite of our patient's hypertension. Plus, they have virilization due to the high androgens, so it conflicts on both blood pressure and the androgen status here.
Okay, and the last two. A, 3-hydroxysteroid dehydrogenase deficiency, and D, aldosterone synthase deficiency.
3-HSD is a very early enzyme needed for basically all major steroids. Deficiency causes low cortisol, low aldosterone, and low androgens. Typically presents with severe salt wasting, hypotension. Doesn't fit. Aldosterone synthase is the very last step in making aldosterone. Deficiency means low aldosterone, hypotension, often salt wasting. Again, doesn't explain the hypertension and high aldosterone seen here. This is the other side of the hypertensive CAH coin. We have a 3-week-old male infant. Key findings: virilized genitalia, he has hypertension and mild hypokalemia.
And the labs: low cortisol, high 17-hydroxyprogesterone, which confirms a block somewhere downstream, but the really crucial finding is elevated 11-deoxycorticosterone, or DOC.
Right. That triad, low cortisol, signs of androgen excess, virilization, and hypertension, specifically with high DOC points squarely at C, 11-hydroxylase deficiency, causing accumulation of mineralocorticoid precursors.
Okay, let's trace this pathway blockage. Where exactly is 11-hydroxylase, and how does blocking it cause both the virilization and the hypertension?
So 11-hydroxylase does two key jobs later in the pathways. It converts 11-deoxycortisol into cortisol, and it converts DOC into corticosterone, which is a precursor to aldosterone. If this enzyme is deficient, both 11-deoxycortisol and DOC pile up behind the block.
But what happens to those piled up precursors?
Two things happen simultaneously. First, the backup shoves precursors sideways into the androgen pathway. Result: androgen excess, causing the virilized genitalia in this infant boy. Second, the intermediate DOC accumulates to very high levels.
And DOC itself acts like a mineralocorticoid.
Exactly. DOC isn't aldosterone, but it has significant mineralocorticoid activity on its own. When levels get really high, it binds to the mineralocorticoid receptors in the kidney, just like aldosterone would.
Causing salt and water retention.
Yep. Sodium and water retention, volume expansion, potassium wasting, leading to the hypertension and hypokalemia observed in the patient. So the hypertension isn't from true aldosterone excess, it's from DOC excess acting like aldosterone.
This really clarifies the hypertensive CHH pair. So, quick recap for everyone. Hypertension plus low androgen amenorrhea. Think 17-OH deficiency. High aldosterone is the driver. Hypertension plus high androgens virilization. Think 11-OH deficiency. High DOC is the driver. Q78.
That's the essential framework. Use the androgen status to pick the right hypertensive variant.
Okay, let's just reinforce why the others are wrong here. Why not B, 21-hydroxylase deficiency again. It causes virilization too.
It does cause virilization, yes.
Yeah.
But as we said, classic 21-OH deficiency blocks aldosterone production, leading to salt wasting and hypotension. Doesn't fit the hypertension. While there are some milder forms, they don't cause the characteristic high DOC levels seen specifically in 11-OH deficiency. That high DOC is key here.
And we already established why 17-hydroxylase deficiency is wrong. It causes low androgens, the opposite of this patient's virilization.
Correct. And aldosterone synthase deficiency and E3-HSD deficiency both lead to salt wasting and hypotension, contradicting the clinical picture.
Is fascinating. It really exposes a crucial protective mechanism in the kidneys. We've got a 32-year-old man with all the signs of mineralocorticoid excess hypertension, low potassium hypokalemia, and metabolic alkalosis. Classic triad.
The labs throw a curveball. His cortisol level is high normal, maybe slightly elevated, but his plasma aldosterone level is suppressed. It's low.
So his body is clearly saying, stop making aldosterone, yet he looks like he has way too much mineralocorticoid effect. What's going on?
It means something else is hitting the mineralocorticoid receptor, MR, in the kidney. An imposter. And the culprit, given the clues, is cortisol itself. The mechanism is 11-HSD2 deficiency leading to cortisol-activating mineralocorticoid receptors. Cortisol circulates at concentrations maybe 1,000 times higher than aldosterone. Both hormones can actually bind to the mineralocorticoid receptor with pretty similar affinity.
1,000 times more cortisol? So if it could freely bind, aldosterone wouldn't stand a chance.
Exactly. The aldosterone signal would be completely drowned out by the massive background noise of cortisol. The body needed a way to protect the MR to make sure it only listened to aldosterone. That's where 11-HSD2 comes in. It's located right there in the kidney tubules, and its job is to grab cortisol and rapidly convert it into inactive cortisone.
Like a bouncer at the door of the mineralocorticoid receptor, only letting aldosterone in.
That's a great analogy. It's the shield. But in this patient, that shield is down. Maybe it's a genetic defect. Maybe they've been eating way too much black licorice, which contains glyceric acid that inhibits the enzyme. Whatever the reason, 11-HSD2 isn't working.
So now the high normal cortisol, which is super abundant, it can waltz right in and activate the MSAR result. Massive sodium retention, hypertension, potassium loss. The body responds correctly to the resulting volume expansion by suppressing the renin-angiotensin-aldosterone system, RAAS, which is why the true aldosterone level is low. That suppressed aldosterone in the face of mineralocorticoid excess symptoms is the hallmark of this condition. Apparent mineralocorticoid excess.
Okay, let's challenge the alternatives, because this is subtle. The patient does have high normal cortisol. Why isn't it just B excess ACTH stimulating renal sodium retention? Couldn't high ACTH be causing some effect? Well, if it were primary ACTH excess, like Cushing's disease, ACTH would be high, driving the high cortisol. While that high cortisol volume would cause sodium retention, the key differentiator here is the profoundly suppressed aldosterone. In Cushing's, you might see aldosterone be normal or even slightly stimulated by ACTH initially or suppressed later due to volume. But the mechanism described in A, the failure of the protective enzyme allowing ambient cortisol access to the MMR, is the specific reason for this unique lab pattern. Option B suggests ACTH itself is the primary driver of sodium retention, which isn't quite right. It's the cortisol gaining access because 11-HSD2 failed.
Cortisol normally cannot bind mineralocorticoid receptors. Why is that definitely wrong?
Because it absolutely can. That's the whole reason 11-HSD2 needs to exist. If cortisol couldn't bind the MR, this entire disease entity wouldn't be possible and the enzyme would be pointless. Its sole purpose is to prevent that binding under normal circumstances.
Got it. And E, cortisol excess, always stimulates aldosterone secretion.
Nope, that mixes up the axis. Sustained high cortisol leads to volume expansion and hypertension. The body's response to hypertension is to suppress the RAS system, which includes suppressing aldosterone. So cortisol excess ultimately leads to aldosterone suppression via pressure feedback, not stimulation.
And finally, C, cortisol clearance is impaired in the liver.
If the liver wasn't clearing cortisol effectively, levels would rise systemically, sure. That would certainly make the problem worse if 11-HSD2 was also faulty. But impaired clearance alone doesn't explain the specific phenomenon of mineralocorticoid receptor activation despite suppressed aldosterone. The core pathology is the failure of that kidney-specific enzyme shield, 11-HSD2. That's the primary defect described here.
Okay, switching gears now to the thyroid. A 32-year-old woman feeling hyperpalpitations, anxiety, losing weight even though she's eating more, shaky hands.
And she has the really specific physical signs, too, a goiter, but it's diffuse, smooth, not tender. And importantly, mild proptosis, that bulging of the eyes.
The labs confirm hyperthyroidism. TSH is basically non-existent, less than 0.01, while free T4 is high, and the clincher. The radioactive iodine uptake scan shows uptake is diffusely increased across the whole gland.
Put all that together, diffuse goiter, eye signs, suppressed TSH, high T4, diffuse radioiodine uptake, and it spells Graves' disease. The mechanism has to be B thyroid-stimulating immunoglobulins activating the TSH receptor.
Explain that autoimmune process. How do these antibodies cause this?
In Graves's, the immune system mistakenly creates antibodies called thyroid-stimulating immunoglobulins, or TSI. These TSIs happen to look a lot like TSH to the TSH receptors on the thyroid cells.
So they trick the receptor.
Exactly. They bind to the TSH receptor and activate it just like TSH would. But unlike TSH, which is regulated by feedback, these antibodies just keep stimulating the receptor constantly, 204/7. This drives the entire gland to overproduce T4 and T3, hence the diffuse uptake on the scan.
And the pituitary sees all this excess T4, T3.
And does its job perfectly. It shuts down its own TSH production via negative feedback. That's why the TSH is suppressed to near zero. The eye signs, the ophthalmopathy, that's thought to be due to related antibodies attacking tissues behind the eye.
Okay, so that suppressed TSH is key evidence against a pituitary problem. Why is a TSH secreting pituitary macroadenoma incorrect?
Because if the pituitary itself was the source of the problem, a tumor pumping out TSH, then TSH would be high, not suppressed. A high TSH driving high T4 is secondary hyperthyroidism. It's rare, but the TSH level tells you instantly it's not Graves. Suppressed TSH means the pituitary is responding normally. The problem is downstream.
Makes sense. What about the hypothyroidism mechanisms? C, decreased synthesis of thyroid hormone due to iodine deficiency, or D, inhibition of thyroid peroxidase by autoimmune antibodies.
Those cause the opposite problem, too little hormone. Iodine deficiency means you don't have the raw material. Inhibition of TPO, which is the key enzyme for making hormone, seen in Hashimoto's thyroiditis, means the factory is broken. In both cases, low T4, T3 would cause the pituitary to increase TSH output, trying to whip the failing gland into action. So you'd see high TSH, low T4, completely different from our patient.
And similarly for E, destruction of thyroid follicles by cytotoxic T lymphocytes.
Right, that also describes Hashimoto's, usually leading to hypothyroidism as the gland fails over time. While some thyroiditis can cause a temporary release of stored hormone, causing transient hyperthyroidism, the sustained picture here with diffuse uptake and the specific antibodies points clearly to Graves. Lymphocyte destruction ultimately leads to gland failure and high TSH. All right, takes us to another cause of hyperthyroidism, toxic multinodular goiter, or TNM. And this one focuses on treatment. We have a 60-year-old woman, typical hyperthyroid symptoms, palpitations, weight loss, can't stand the heat. Labs show suppressed TSH, high T4, T3.
And the thyroid scan is the key diagnostic piece here. It shows multiple nodules that are hyperfunctioning, taking up the iodine tracer avidly, while the rest of the gland might be suppressed. So areas of the thyroid have gone rogue, basically.
Exactly. These nodules have developed mutations that make them produce thyroid hormone autonomously, independent of TSH stimulation. The question asks for the preferred definitive therapy. The answer given is E, radioactive iodine ablation, RAI.
Why is RAI often preferred for this condition?
Because it targets the problem directly and effectively, usually without surgery. Those autonomous hyperactive nodules are greedy for iodine. They need it to make all that extra hormone. So when you give radioactive iodine, I-131, these hot nodules preferentially suck it up much more than the surrounding normal thyroid tissue, which is suppressed because the TSH is low.
And the radiation kills off just the overactive cells.
Precisely. The localized radiation destroys the cells in those autonomous nodules, curing the hyperthyroidism. It's highly effective for TNM and avoids the risks of surgery.
Speaking of surgery, why isn't B, immediate total thyroidectomy, considered the preferred option? It definitely removes the source.
Surgery is definitely an option, and it's a treatment of choice if there's any concern about cancer or if the goiter is huge and causing compression symptoms. But it's more invasive. For an older patient, like the 60-year-old, surgery carries risks, anesthesia risks, the risk of damaging the parathyroid glands leading to permanent hypocalcemia, risk to the vocal cord nerves. RAI avoids those surgical risks, so for uncomplicated TNM, it's often preferred as the first-line definitive treatment.
Okay, preference versus absolute cure. That makes sense. What about just using medications long-term? Why not A, Methimazole in all cases, or DPTU for life.
Antithyroid drugs like methimazole, MMI, or PTU are great for controlling the symptoms and getting the hormone levels down, maybe before RAI or surgery. But they don't fix the underlying problem, the autonomous nature of the nodules. As soon as you stop the medication, those nodules often just start overproducing hormone again. Relapse rates are high. Plus, long-term use carries potential side effects, especially the liver risk with PTU. So they're usually not seen as a definitive, lifelong solution for autonomous disease.
Right, they treat the symptoms, not the cause. And finally, C, levothyroxine replacement.
That's thyroid hormone replacement. You give that for hypothyroidism when the gland isn't making enough hormone. Giving it to someone who's already severely hyperthyroid would be, well, adding fuel to the fire. Completely wrong direction.
All right, final section.
We have a 65-year-old man. He has a known squamous cell carcinoma of the lung. He comes in feeling tired, constipated, classic non-specific symptoms that can point towards high calcium.
And the labs confirm it. Calcium's very high, 13.2 milli-GDL. Phosphate is low, 2.5 milli-GDL. But the hormone levels are the real diagnostic linchpin. His parathyroid hormone PTH level is suppressed, but another peptide, PTH-related peptide, PTHrP, is elevated.
That specific pattern, high calcium, low phosphate, suppressed PTH, but high PTHrP, is the absolute signature of humoral hypercalcemia of malignancy, or HHM. The mechanism is C, tumor secretion of PTHrP, mimicking PTH action.
Let's focus on that suppressed PTH for a moment. Even before we knew the PTHrP level, if we just saw high calcium, low phosphate, why does seeing a low PTH immediately tell us the problem isn't the parathyroid glands themselves?
Because the parathyroid glands are exquisitely sensitive to calcium. If calcium is high, healthy parathyroid glands should shut down PTH production completely. The fact that PTH is suppressed proves the glands are sensing the high calcium and responding appropriately. Therefore, the calcium must be coming from somewhere else. If it were primary hyperparathyroidism, a parathyroid tumor, the PTH would be inappropriately high, or at least high normal, ignoring the high calcium feedback.
So the suppressed PTH points away from the parathyroids, and the elevated PTHrP tells us where the signal is coming from. Explain PTHrP.
PTH-related peptide is a protein that some tumors, especially squamous cell cancers, can produce. It's structurally similar enough to PTH that it binds to the same PTH receptors in bone and kidney.
So it acts just like PTH.
Pretty much. It stimulates bone resorption, releasing calcium, increases calcium reabsorption in the kidneys, and importantly, increases phosphate excretion by the kidneys.
Primary hyperparathyroidism again.
Ruled out because PTH would be high or inappropriately normal, not suppressed.
What about D, vitamin D intoxication? That can also cause high calcium and suppress PTH.
True. Vitamin D toxicity raises calcium by increasing gut absorption of both calcium and phosphate. So while PTH would be suppressed, you typically see high calcium and high or normal phosphate. The low phosphate level in our patient is characteristic of PTH or PTHrP action due to that direct effect on renal phosphate wasting. Vitamin D doesn't typically cause that phosphaturia.
Okay. What about causes related to kidney failure or bone destruction? Why not A, renal failure causing secondary hyperparathyroidism?
Secondary hyperparathyroidism happens when the kidneys fail, can't activate vitamin D properly, and can't clear phosphate. The body senses low calcium and high phosphate, driving PTH levels very high in response. So the pattern is high PTH, low calcium, and high phosphate, basically the chemical opposite of our patient.
Got it. And E, bone metastases secreting calcitonin.
Well, first, calcitonin lowers calcium, doesn't raise it. Second, while bone mets can cause hypercalcemia by physically destroying bone, local osteolytic hypercalcemia, that doesn't usually involve PTHrP. The specific hormonal profile here, suppressed PTH, elevated PTHrP, points directly to the humoral mechanism mediated by the tumor peptide, not just bone destruction. Okay, metabolic consequence of too much growth hormone. We've got a 48-year-old man. He has confirmed untreated acromegaly high IGF-1, and his GH doesn't suppress when he drinks glucose, which confirms the diagnosis. Now he's complaining of drinking a lot and peeing a lot, polydipsia. And his fasting glucose is high, 155 milli-GDL.
So, established acromegaly, now developing symptoms and lab evidence of diabetes. What's the link? The question asks for the best explanation for his hyperglycemia. It's B, GH-induced insulin resistance in peripheral tissues.
Right. Growth hormone, especially in excess, is a major counter-regulatory hormone. It directly opposes the action of insulin, particularly in muscle and fat tissue. It makes these tissues resistant to insulin's signal to take up glucose.
So the body's cells just don't respond well to insulin anymore.
Exactly. Widespread insulin resistance develops. The pancreas tries to compensate by pumping out way more insulin, trying to overcome this resistance, but eventually, especially with long-standing GH excess, the pancreatic beta cells can get exhausted and just can't keep up. Insulin production falls relative to the massive resistance, and blood glucose levels rise. Diabetes is a very common complication of untreated acromegaly, directly driven by the GH excess itself.
So why wouldn't we pick D, pancreatic failure, as the primary cause? Isn't that the ultimate problem in type 2 diabetes?
It's the final step, yes, but the initial trigger here, the root cause, is the insulin resistance induced by the excess GH. The beta cells fail because they're being overworked trying to overcome the GH-induced resistance. So the resistance is the primary pathophysiological link to the acromegaly itself, making it the best explanation for why the hyperglycemia started.
Okay, that makes sense, cause versus effect. What about A, cortisol co-secretion by pituitary adenoma? Some pituitary tumors make multiple hormones, right?
They can, it's possible. And excess cortisol also causes insulin resistance. But we know this patient has acromegaly. GH excess is a perfectly sufficient and indeed very common cause of diabetes on its own. We don't need to invoke a second unproven hormone co-secretion unless there's specific evidence for it. The most direct explanation linking the known disease, acromegaly, to the complication, diabetes, is the effect of GH itself.
Got it. Stick to the known pathology. Now, clarify IGF-1's role. Why is C excess IGF-1 causing hypoglycemia wrong? Doesn't IGF-1 stand for insulin-like growth factor?
It does, and structurally it is similar to insulin. In very high doses, it can have some weak insulin-like effects and potentially lower glucose. However, in acromegaly, the powerful anti-insulin diabetogenic effects of the parent hormone, growth hormone, vastly overwhelm any minor insulin-like effect of IGF-1. The net clinical result of GH-IGF-1 excess is insulin resistance and hyperglycemia, not hypo.
Okay, GH's effect wins out. And finally, E, exogenous steroid use.
Just like before, there's no mention of the patient taking outside steroids. We always try to explain the findings based on the internal physiology presented in the vignette first. The acromegaly provides a direct, strong explanation for the diabetes.
The patient is a 50-year-old man. He has those classic neuroglycopenic symptoms when fasting, confusion, sweating, Whipple's triad territory. Labs confirm very low glucose at 38 milli-GDL. Insulin level is high. And crucially, his C-peptide level is also elevated. Plus, a screen for sulfonylurea drugs, which make you release insulin, is negative.
Okay, that high C-peptide is the absolute key here. C-peptide is cleaved off when your own body makes insulin from proinsulin. It's released in a 1.1 ratio with endogenous insulin.
But injected insulin doesn't have C-peptide.
Exactly. Commercial insulin is just the final insulin molecule. So if insulin is high and C-peptide is high, it proves the insulin is coming from inside the patient's body. It rules out an injection. The negative drug screen rules out sulfonylureas. So we're left with endogenous hyperinsulinism.
The usual suspect for that is an insulinoma, right? A tumor making insulin.
That's the most common cause, yes. But the answer provided here points to a rarer, more complex mechanism. C, autoantibodies binding insulin and releasing it intermittently.
Insulin autoantibodies, how does that work?
This is called insulin autoimmune syndrome, or IAS. The patient develops antibodies that bind to their own insulin. Think of these antibodies like little sponges soaking up insulin in the bloodstream.
Okay, so they bind it.
Mm-hmm.
Then what causes the hypoglycemia?
The problem is the release kinetics. The binding isn't permanent. Under certain conditions, maybe changes in glucose levels or blood pH, these antibodies can suddenly let go of a large amount of bound insulin all at once. It's like the sponges suddenly get squeezed out.
A massive, unpredictable dump of insulin.
Exactly. This leads to sudden, severe episodes of hyperinsulinemic hypoglycemia that can be quite erratic and unpredictable, maybe happening post-meal sometimes too, not just fasting.
How did that differ from insulinoma, option E, that also causes high insulin and high C-peptide?
It does, but an insulinoma, being a tumor, usually secretes insulin more constantly or predictably, often leading to more classic fasting hypoglycemia. While both are possible, the potential for erratic, sudden dumps makes IAS, the autoantibody mechanism, a distinct possibility, especially if the pattern of hypoglycemia seems unusually unpredictable. It's a rarer but important differential.
Okay, so the pattern might distinguish them. Now, let's definitively use C-peptide to rule out B, exogenous insulin injection, Why is that impossible here?
Because, as we said, injected insulin has no C-peptide. If the high insulin was from an injection, the patient's own pancreas would shut down production in response. So you'd see high insulin, but low or undetectable C-peptide. The high C-peptide here absolutely proves endogenous production.
Crystal clear. And A, sulfonylurea ingestion.
Sulfonylureas make your beta cells secrete insulin, so they do cause high insulin and high C-peptide, mimicking endogenous production. But the vignette explicitly states the drug screen was negative, ruling that out.
Okay. And last one, D, glucagon deficiency.
Glucagon is a counter-regulatory hormone. It raises blood sugar. If you're deficient, you might be more prone to hypoglycemia, especially during fasting, because you can't fight the drop effectively. But glucagon deficiency doesn't cause high insulin levels. It fails to explain the hyperinsulinemia, high insulin, and high C-peptide. That is the core finding here. You need something driving insulin up, not just failing to counteract it.